Okay, 10. Good afternoon. Good morning, actually, from Miami Beach. Is Dr. John Bennett for Neurosurgical TV Super Sunday. Welcome. Today we have let me get off the live. Okay, okay, I'm sorry, folks. Little glitches here. Okay, so this is our first time with Zoom, actually televising. Will be a little awkward, but we have the pleasure of having Rosanna, and she'll introduce herself. She's going to talk about the natural history of intracranial meningiomas. But first, let's get introduced to the panelists right now. Hello, Hera. Can't hear you, Hera.
Hello, can you hear me now?
Yeah, now we can hear you.
Yeah, this is Hira from Pakistan. I'm heading the ACNS Young Neurosurgeons, and it's a pleasure for all of us to be here. And we have a good panel today. So let's start with it. Thank you.
Okay, very good, Hera. Thank you. Margarita, could you please introduce yourself to Rosanna?
Hi, Rosanna. Good morning. My name is Margarida Conceição. I'm a neurosurgeon from Brazil. Actually, I live in Porto, Portugal. It's a pleasure hear your presentation. Welcome.
Thank you, Margarita. Okay, Rosanna, could you please introduce yourself, and then you can start your presentation?
Yes, thank you very much for the chance to give this talk. A great honor, and I will talk about the natural history of intracranial meningiomas. I trained with Professor Ernest Liem in Helsinki for 5 years, and then as well with Professor Xu Bin in Shanghai at Fudan University. And then I'm now working in London. So the reason why I'm interested in meningioma, I started to study meningioma in 2007. I did my PhD with Professor Nesniemi about meningioma regarding the macrosurgical technique. Now, since I moved to UK, I saw that we have an increased number of incidental meningiomas. And in first hospital I work in this country, extremely busy hospital with a catchment area of around 3 million people. So, and we saw very many meningiomas. Very busy hospital, and I had the opportunity to do as well many complex skull-based meningioma surgery. Can you? I don't know, I cannot see the presentation. I don't know if you can give me back.
We can see your presentation well.
You can see, but I cannot see myself.
Okay, can you, you are screen sharing actually, and you need to go back to your PowerPoint and you need to start
you see?
presentation.
See.
Okay, you need to go to your PowerPoint again.
Yeah.
I can see the PowerPoint pretty good, Kira. You can see it?
Yeah, we can all see that, but she's not able to see for herself, so she needs to go back to her PowerPoint.
Okay.
Yes, now it's fine. Yeah. Yes.
I don't know what. Let's see. So, I mean, I can see just in black. Sorry.
It's. I mean, the slideshow isn't working.
Sorry.
Your slideshow isn't working.
Yeah, I'm exiting the full screen now.
Can you go back to your PowerPoint presentation, please?
Yeah. Just because I have all the participants in mind, just let me see.
Okay, can you just stop screen sharing for once and go back to your PowerPoint and then start screen sharing again?
Yeah, sorry.
Okay, you screen share again and you go back to your PowerPoint now.
Yeah, okay. Can you, okay, now let me put in, can you see me?
Yes, we can see you. We can see you.
Let me see now the, let me put in the sharing again. Sorry.
It's okay. It's new for all of us.
Yeah, it's okay. It's okay. This is new. This is a very new thing for every one of us. So.
Okay, now should be okay. Can you see share screen?
Yes. Now. Yes. Yeah, we can see this now.
Okay. Okay, so let me continue.
Yeah.
And maybe I can leave it in this way. Is that okay?
Yeah, that's fine. That's fine. That's fine. You
Maybe
just
can be
carry
back.
on with your presentation. Yeah.
Okay.
Fine. Yeah.
So as you know, the meningioma are the most frequent intracranial benign tumors and account of 38% in female, 20% of male. So we had, especially in West countries, a facility to do the neuroradiology investigation. And for that reason, we have an increased number of this incidental meningioma in majority of the patients asymptomatic. And we don't have a really clear guidelines how to follow up this patient, because if it's a small meningioma, asymptomatic patient, of course, we have the choice and also the right to say to the patient that the surgery maybe is not really the first option. And also many of these meningioma can be stable for many years. So we have a different option of management, like watch, wait, and rescan, microsurgical removal, radiosurgery, or fractionate radiotherapy. So we had a quite a good series of 136 patients, which is the second largest series in the world. And this article, this clinical research, which is quite original, will be published in the coming weeks. The article has been just accepted in the European Journal of Neurosurgery. Majority of the patients were female, 132, and 34 were male, with a mean age of 65. We follow up with this patient between 2002 and 2016, and this is the series of one neurosurgeon in this hospital where I work 2 years ago in Romford, so northeast London, with a big catchment area. Now, as you see here, the majority of these patients were symptomatic with stable symptoms and minor symptoms during the follow-up. They were 87 symptomatic and incidental 49, with a good Karnofsky score of 85. And you can see here all the symptoms of this patient. I study also, and I subdivided this comorbidities in this were the small, the minor symptoms which were stable during the follow-up related to the meningioma. But you can see here how 109 patients had comorbidities. And some of these comorbidities could prevent or make at high risk the surgical removal of the meningiomas. So on the left, you see that the 70 patients had cancer, 3 of them metastatic cancer, then ischemic heart disease, chronic kidney disease, and as well COPD. So on the right, we have this comorbidities we face every day with our neurosurgical patient, which of course do not prevent a general anesthesia of a neurosurgical intervention. Location of the meningioma was for 92 patients supratentorial and 44 infratentorial, and 80 skull base location. Yes, I divided as well left, right, but just to understand if there were some association with the progression, I will explain you later. And you can see here that skull base location was 55 supratentorial and 25 infratentorial. So this is an example of a 62-year-old lady with no symptoms and suprasellar cavernous sinus meningioma. So this meningioma remains stable after 8 years of follow-up. The size of the meningioma was for the majority medium, between 2 and 4 centimeters. So I did this classification because when we did the microsurgical technique meningioma study in Helsinki, we use this classification. So many times you see only two sides of meningioma, less than 3 centimeter or more than 3 centimeter. But I prefer to do this 3 subgroup, less than 2 centimeter, between 2 and 4, and more than 4 centimeters. So majority was between 2 and 4. We associated this size of the meningioma with the progression, and there was no significant statistical association. So a size, even less than 2 centimeter, or more than 2 centimeter, or less than 3 centimeters, so just the 2 subgroups, and more than 3 centimeter is not really associated with progression of the meningioma. And then the 35 patient had edema and the 34 calcification. We couldn't do CT in 26. The follow-up was around mean 51 months, so quite a long follow-up, and the majority of this patient remained stable at the end of the follow-up, clinically and radiologically. So you can see here 86. There was a progression radiologically in 23, clinical progression in 13, and both the clinical and radiological progression in 14. So majority of the patients were stable. So I was interested to understand why the majority of these patients remain stable during the follow-up, even, long follow-up, and I wanted to understand how to predict them. So basically, if you have a small meningioma in young patients, maybe you should have some radiological characteristic for which you could say, okay, this for sure will progress, so we should do an early surgery, we should not follow up, which this will make also surgery quite easier if you have a small meningioma. On the other hand, we have also medium-sized meningioma, which can remain stable during the follow-up, and with patients with minor symptoms stable during the follow-up, who may not need absolutely general anesthesia or surgery for this meningioma. We studied the subgroup radiological progression, and what I found is that these were the characteristics of the patients. So 37 patients with long follow-up, 14 were incidental, symptomatic 23, and skull-based 21. So majority of them skull-based. Edema was in 16 of these patients, and the size, as you can see, majority was medium size. So I found in univariate analysis that hyperintensity in T2, hyperintensity in flare, and the edema are associated with progression. And this edema is something that we found in literature, so it's not something new. We well know that the edema is associated with progression of the meningioma. And calcification is associated with non-progression. Age as well is significant. So old patient seems not to progress. And this is the statistic graphic of the age showing that there is a correlation with the age. Younger ages seem to progress than older. We don't have so many patients very young because, of course, young patients, we did the surgery, early surgery, so we didn't recruit for this study. And this is an example of an 80-year-old lady, yes, with calcified CP angle meningioma. So as you can see, in 4 years, this meningioma partially calcified remains stable. And this as well, falx meningioma after 6 years remains stable. This is an interesting case of right temporal convexity tumor meningioma as well. So you can see as this meningioma remains stable, and unfortunately this patient developed subarachnoid hemorrhage for posterior circulation aneurysm and died for the subarachnoid hemorrhage 4 years after. He was still under the follow-up. So this just 1 year of follow-up of this patient, 81-year-old male with incidental right middle fossa meningioma. So you could say that I would operate this patient at the first outpatient clinic. And, you know, if the patient has minor symptoms, has many comorbidities, the risk of the meningioma operation should be considered. And there was no progression for 1 year. Of course, if we show progression, you need to consider the operation according with all the general condition of the patient. And this a patient who had symptoms and then underwent a neurosurgical intervention of removal of the meningioma. So we didn't wait as the patient developed a visual problem. So the observation, I think it's important to understand the natural history of the meningioma. So we have here two different cases. I don't know if you can see, this is 82-year-old female with medical comorbidities. She was blind since 20 years, and the meningioma was stable, no progression in 8 years. And here you have a young lady, 40, who had a very rapid increase of the meningioma size in just a few weeks. So, of course, we did a surgery, and there was a grade 1 meningioma. I must say that those patients who had surgery, so this 22, they had all grade 1 meningioma, so benign. And as you can see, that the 47 are still under observation, 44 were discharged, and 23 ended with surgery, 12 with radiotherapy, and then a biopsy radiotherapy. We had 4 patients lost at the follow-up, and 5 refused surgery. So we calculate as well the cost of this patient who were discharged, and you can see that there was quite a significant cost in terms of MRI in that outpatient clinic, with almost £200,000, which could have been saved if we knew already which were the characteristics of the radiologic characteristic of the meningioma, which can predict the progression. So what I wanted to do is a meningioma database to predict those patients who progress, so who can benefit for an early surgery. Because I think in some patients, we should not wait, we should do surgery as soon as we have the diagnosis. But I'm not so sure now which are the, basically we don't have the guidelines, worldwide guidelines to understand it, to say, oh, this patient needs an early surgery, or this one we can discharge because it will never progress. I guess it will be a combination factor. So radiology characteristic, for example, hyperintensity in T2 could be one, which I found as well in the literature as a predictive factor of the meningioma. Edema, we well know, is a predictive factor of progression of the meningioma, and calcification, we well know, that are associated with no progression. But I'm sure that there are also other factors. For example, in female age, we know that there is an association with hormone and the progression of the meningioma, like, for example, progesterone. So probably after 52, 53 years, so after a certain age, we may not have any progression of meningioma in female sex. But I didn't find an association with sex and meningioma progression in this cohort of patients. We need more patients, and definitely we need a long follow-up. So that will be I think my future study about the meningiomas. I would like to thank my statistician, who is Christian Berner, who is still he works in Helsinki. I'm still connected with Helsinki University for some project, and as well the medical student who helped me in the data collection, who work in Queen's Hospital in Romford, so Taslim and Francis. So thank you for your attention. and I'm happy to answer the question, of course.
Thank you. Thank you so much, Dr. Rosanna. We have two new panelists with us, Dr. Juma Magogo and Dr. Deepak. May I please request Dr. Juma to introduce himself, and we can then proceed with the question and answer session. Dr. Juma? Hi, Dr.
Yes,
Juma.
Hi, how are you?
I'm good. How are you?
I'm fine. Good evening, everyone.
Good evening. Could you please introduce yourself to us?
Yes, sure. I am Dr. Juma Magogo. I am from Tanzania. I'm a young neurosurgeon. I finished my training 2 years ago.
We
Now I'm
cannot
doing
see
my
you. Can
fellowship.
you just put your camera a little? Yeah, now we can see you better. Yeah.
Okay.
Yeah.
I'm now doing my spine and neurosurgery fellowship in India. So
All
my
right.
pleasure to meet you all here. And thanks for the presentation.
Thank you. Any questions, Dr. Juma, from Dr. Rosanna regarding
Actually,
meningiomas?
I was caught up late, so I didn't get much of the content. I think
Okay.
it was a nice presentation. So maybe
Okay,
let others comment, then I may get some questions later.
Okay, thank you so much. Dr. Deepak, can you please introduce yourself? Hello, Dr. Deepak, can you hear us? Hello, Dr. Deepak, are you there? Okay, I guess is not here. Okay, Dr. Margarita, do you have any questions or any comments? You're muted, you're muted.
Are you hearing me now?
Yes, we can hear you now.
Okay. Thank you, Rosanna. It's a beautiful presentation. Do you correlate some kind of pathological anatomy pathological with the progression of the meningiomas? Do you have this data to present us?
So we wanted to do the methylation of those meningioma who progress and who require surgery. We wanted to do the methylation of the sample. We still not yet done because there is this recent publication. They say that the methylation is associated with the malignant or somehow more aggressive behavior of the meningioma. So we need to do that. But all of them were grade 1, all of them. So not grade 1, a typical grade 2. Yeah.
Okay, and do you are planning to study some correlation with cytokines and the type of meningioma who progress in the future? Oh,
probably
sorry.
Yes. I wanted just now to do the prospective study to enroll those patients who are incidental. Because in West Country we have this facility of neuroradiology investigation to do. So many patients do MRI for different reasons, just for a simple headache, for not really meningioma related symptoms. So majority of these patients, apart of this study, but we see every day many of patients are really asymptomatic. So we needed to understand which one are those who progress and those not, because some of them remain stable all life.
Okay, thank you very much.
Thank you. Thank you for attention.
Okay, thank you so much. So this is, any more questions? Dr. Juma, now do you have any questions or something or any comments?
When she was about to finish the slides, I heard her saying about the relation between meningioma and progesterone. And was like curious, is it the relation, is it between progesterone or estrogen?
No, actually, I'm just saying that what I want to say you, I'm doing another publication, another article, another clinical research about association with progesterone receptor and also symptomatic meningioma. So there is this progesterone receptor seems to be the, especially in female, the receptor that are present in meningioma for 90%. So the most frequent, so there is a very strict association, but now I didn't present those data because I'm just refining the research, the data about that. So, for example, we have a few cases of a patient, a female patient who became symptomatic during pregnancy. And this is because during pregnancy we have the highest level of progesterone. So this seems to stimulate the meningioma cells. So in which way, we don't know yet. So that will be interesting. And then after pregnancy, this is symptom. So the patient became symptomatic during pregnancy, and then afterwards, the symptoms disappear. And then you do the MRI, you discover the meningioma. So, and we operated all of we have 5 cases, so we operate all of them, and the percentage of progesterone receptor was almost 100%. So there is a very clear correlation. But in this series that I presented now, sex seems not to be associated. I did also the cutoff with age 52, like, you know, the age where female usually reach the menopause, and there was not really association. So we definitely need a larger number of patients to see this. And then, of course, those patients who need surgery, it's interesting to see all the receptor study, methylation, all of this, so to understand better the natural history of the meningioma and as well the progression, because meningioma is benign tumor, but as you know, can be very aggressive. We can have patients with multiple even if they are
Okay, I guess.
Yeah, we have just lost her.
Yeah, I think she just disconnected. She got some disconnection. Okay, so we move to our next presentation, which is actually mine. Let me just check on Dr. Rosanna if she's coming back. Otherwise, we'll start mine. Give me a few minutes, please.
Oh, sorry. Are you there, Hira?
No, we're waiting. We just joined again. All right, thank you.
Oh, okay. Okay, you're doing the next presentation, right?
Yeah, but she's joining in again for a moment, and then I'll start when she comes. There was some interruption in her connection, so she's joining. Yeah, there she is.
Oh, okay.
Okay.
Do you want to start your presentation?
No, yeah, Dr. Rosanna, you were giving your answer. Can you?
Oh, okay.
Okay.
Okay, go ahead.
I'm sorry,
handle
Dr.
it,
Rosa. I don't know if did you have the chance to hear my answer?
Yes, I had
So
the
yeah, that's what I wanted to do. I mean, to study better, because I think some meningioma are very aggressive, and
Okay.
yeah, surgical technique, of course, requires skill and quite. So it's not really so stressful tumor, I think, somehow.
Okay.
Okay.
Thank you so much.
Okay, all right.
Thank
you. Thank you, Dr. Rosanna. Okay, John, so we start with mine. Thank you so much, Dr. Rosanna, for your presentation. It was very informative. And I request you to stay here if you would like to for the rest of the call. Okay, thank you so much. John, do we start with mine? Okay, we can't hear you, John.
Okay, new on this platform. Okay, it gives me great pleasure to introduce Hira Burham, who not only does the great graphic that we have to advertise it, but she put together this program, and I really appreciate that. And today she's going to do double duty and give a presentation. But first, let's quickly go around and meet the panelists again, okay? Because we're going to separate these videos. Hello, Margarita. Okay, you need to unmute, Margarita. Okay.
Hello, Professor. Good morning. How are you? Hi, everybody.
Hi.
Okay, Margarita is a neurosurgeon from Portugal. Excuse me, from Brazil. She's in Portugal, correct, Margarita?
Right now I live in Porto. Yeah.
Very good. Welcome. And Rosanna, could you please introduce yourself? Unmute and introduce yourself, please. Rosanna, can you hear me okay? Just unmute.
Yeah.
There you go. There you go. Yes.
Yes, I'm Rosanna, and as I said before, I'm now working in London, and I worked before in Helsinki and Shanghai for the university.
Very good. Welcome, Rosanna. And Ipe, good day.
Sorry?
Excuse me. Well, I'm introducing Ipe Cherian. I'd like you to meet him also, Rosanna. If you don't know him, everyone knows Ipe. Ipe, could you unmute yourself, please? You're muted, Ipe.
Hi, John. Hi, Rosanna. Hi, Margarita.
Hi.
Well, I am from Nepal. Good to hear your talk on meningiomas.
Thank you. Welcome, Ipe. And a new addition to the community, Peter Wong. Hello, Peter. Could you please unmute yourself and introduce yourself to the neurosurgeons and the panelists?
Okay. Hi, everyone. I'm a math student currently studying in Italy, Milan.
Oh.
Very good. From
Yes.
Taiwan, studying in Italy. Excellent. Okay, Hira, it's all yours. Please introduce yourself a little bit, and then you can launch into your presentation. And
Okay, thank you, John. I hope you can hear me well.
Yes.
Okay, I'm Hira from Pakistan. I recently graduated and I am pursuing neurosciences in future. I had the opportunity of working with Dr. Cherian on this project, and I would like to present this. We found some good results, so it's worthy of sharing with you all. Currently, I'm also heading the ACNS Young Neurosurgeon Society, so it's a pleasure to be presenting on this forum. I would like to screen share and begin with my presentation. Okay, can you see this? Everyone, can you see this? John? John, you're muted.
Yes, I can see you. Yes,
All
I
right.
can see it.
Can you see the presentation working on?
Yes, ACNS
Okay.
Young Neurosurgeon Society.
Okay. So this is our topic for today, which is basically the study of neurology, of emotions, and a method which we figured out how to control them before they get into extreme. This was published recently in the Journal of Noble Medical College. This is the institution where Professor Ike works. And we got this. This was basically a pilot study, and we intend to proceed this further. So before I start with the actual study, I would like to give a small background on what our study is. Human mind is composed of 4 emotions: fear, anger, joy or happiness, and sadness. Now, there's a complex mechanism which functions in the temporal lobe, and this takes in all the sensory inputs from the 5 senses, and it processes them, and we go for a reaction once we perceive them. If these emotions are manifested in an extreme manner, there's a change in our outcome, which leads to panic in case of fear, rage in case of anger, or maybe laughter or extreme ecstasy in case of joy, and grief when we are extreme sad. So the functional unit of the brain which is responsible for these emotions is the Papez circuit, and this is the part of the limbic system which gives us an output of all the sensory inputs which we receive as emotions. This was one of the reasons that once if the forebrain is put into action and it interferes in the Papez circuit loop, there is a possibility that we stop the emotional progression and we can override those emotions from going too extreme. And probably this was one of the reasons why counting to 10 was one of the modes of controlling one's fears or emotions. So if you see that this is how the Papez circuit continues in a circular loop until and unless it receives an overriding function by the forebrain. So one example is these cutting edge sports, and which also includes neurosurgery, that if we look into what can go wrong, we will never be able to practice this. But the beauty of overtaking an F1 or witnessing such sports or even doing them on our own has their own charm. So we need to overcome that fear, that panic which comes in between our doing these actions and not to stop us from doing this. So there are some people who are very elite in such professions. For example, there will be a difference in an average neurosurgeon or an aneurysm neurosurgeon. So what is it that makes them different? It's the overcoming of fear. And what is fear? This is an emotion which is associated with the amygdala, the papes, and the hypothalamus. So in other words, fear is something which is evoked by the threat of something which can go wrong. And threat in turn is something which causes fear in us. So we begin with our introduction, and theoretically, our emotions are responses to the five senses, as I said before, and the body associates them with the stored memories from the past. Now, this has something very important to do in how we react with any stimulus. For example, the fight or flight response. If you had an experience of being burned by a matchstick, you will never be able to come near it and touch it because that will take you back to your memories of being burned. So you would rather flee away from that. So that is the basic response, the fight and flight, which we experience in response to any stimulus, may it be fear or anything else which elicits the same response. Again, the same story. It's not true that every sensory input will elicit a similar response each time in an individual. For example, if a girl who has been a victim of rape, a touch will not ever make her happy of that feeling. However, if any girl who's not been through that trauma, she will be delighted by that sense. Same is the case with anything. For example, patients who undergo traumatic accidents, road traffic accidents, or any other physical or mental trauma, they will recall that back and react in a similar manner as they had before. So this is the effect of both the social and the personal context in which whatever the signal they are receiving, they process in it. And this is how the preformed memories, they associate with our actions and our response to any stimulus which we seek. And this again remains interesting that one sensory response input cannot result in same responses every time with every person. And this is an example of a girl who might have had a road traffic accident and she's not delighted with sitting in the new car. However, another girl who never had that experience will be very happy and encouraged to drive in that new car. So, what are these extremes of emotions? This is the uninhibited release of stimuli by the Papez circuit. And this continues to go on unless and until there is a stop control over it, which is very much needed, and that is what the forebrain comes in for. These emotions are not only related to our neuronal circuitry, they also have a very important role in the hormonal responses, which include our sympathetic and parasympathetic release and the adrenal glands, which are responsible for the epinephrine and the norepinephrine rush which we experience. So, an example of extreme in emotions is that fear can turn into a PTSD or panic, which is most frequently experienced by such patients. And they always relate that same experience or that same stimulus to that one thing or one event which they went through. Now, we need a cognitive inhibitory control, and this is where the frontal lobe, more precisely the forebrain, comes in, and this allows us for a flexibility in our behavior and even in treatments for PTSD patients. So, you see, if there's an extreme, we'll have happiness converted into ecstasy, sadness into grief, fear into panic, and anger turning into rage, which we do not really want. Now, touching up on neurobiology of fear, here I would like to make a comment is that out of all the four emotions which I mentioned in the beginning, fear has been one of the most studied emotion. That is why we have more data and more workup on fear, on the neurobiology of fear precisely. but other emotions need to be studied equally. So in our study, we took this as a reference, and we studied what the circuitry of the PP circuit is, how is the information processed, how is the relay functioning via the thalamus to the thalamus via the stria terminalis, and what are the functions of the hormonal and the autonomic controls by the pituitary and adrenal glands respectively. So all the sensory information again processes from the five senses conveyed to the amygdala, which is the center of all the emotional processing. Stria terminalis, as we all know, is a pathway which leads output signals from the amygdala to the hypothalamus and thus results in the manifestations of emotions, as we all know. So this is a simple flow chart which says that if emotional stimulus goes into the thalamus, has a relay into the hypothalamus and the thinking record. This is the limbic system which we are talking about, and this gives an output as one of the four emotions depending upon the stored or the pre-formed memories which we have of any event. This is an image from the Nature Neuroscience journal. So now touching upon the amygdala, which is the central organ of the emotional processing, it has many nuclei arranged, and we studied that there's an important role of the lateral and central zones of the amygdala, anterior and medial hypothalamus, and some of the specific regions of the periaqueductal gray matter. And they are the critical but the amygdala in itself is the most critical component. And the lateral and basolateral nuclei are the site where we have learned association, which we are talking about when we say we have preformed memories from the past. The medial nucleus has a modulatory role. So this area has the most extensively researched studied, and there are many reviews about this. And this was one of the places where we also, where we can put in that famous experiment of the controlled and controlled response by the Pavlov experiment of the dog. So this was the most studied aspect of the amygdala there. Now, when we are asked about measuring this, we are talking exactly how to measure emotional processing in the human mind. There are many methods to do that, and these methods like skin conductance responses, galvanic skin reflexes, electromyography, and changes in heart rate, they basically are giving us the result of an output, or more specifically, the autonomic output from the emotional experiences which our body processes. However, there are studies like functional MRI, which is actually detecting the cerebral blood flow in the form of giving high densities or low densities, where we have neuronal activations across the brain. And this area can specifically pinpoint or highlight those regions which are responsible for processing of emotions. More advanced are fluorescent sensors and actuators, which can help us detect how these responses are being conducted. So this is an example of an MRI mapping using functional MRI. Here they are seeing that there's an increased cerebral flow in these areas of the brain, which obviously highlight to the regions of the amygdala and the entorhinal cortex. So there needs to be a stop signal to prevent extremes of emotions from emerging. And this is where the fronto-basal and ganglia circuitry comes into play. Now, this is the basis of sequencing, which Dr. Cheriam will continue in the later presentation. But I would like to put a touch on it by saying that this is the serial order of behavior in which there's a stop in the continued discharge of the autonomic responses. For example, if we start counting from 1 to 100 when we are angry, we suddenly feel that we are no more angry anymore, or there's a decrease in intensity of our anger. So this will help us control, modulate, or even stop the signal of being angry for a longer time. Now, I would like to describe the research which we did, and it was a pilot study, and we hope to look at the basics of this neurology and how can we formulate a method to overcome panic and other emotions from reaching an extreme. So this was the methodology. We had 10 children. Since this was a pilot study, we did not need much participants. They were all aged 10 to 16 years, and they were asked to volunteer for the study. And they were not biased to the input they were given. They were subjected to pictures and video clips which would make them angry, sad, happy, or afraid, or these four emotions. What we used as a measurement tool was the visual analog score, and this was a very simple scale in which we asked them to tell us how happy did they feel or how sad did they feel, and based upon that, ranging from 1 to 9, we recorded their responses. 1 meant that there was no response, 9 meant that they were in extreme response, and the middle figures were somewhat their experiences. So we noted all these responses and collected the data accordingly. This was done before sequencing, and then we asked them to immediately sequence. We asked them to immediately start counting, and the moment they did that, there was another VS recorded, and this was after sequencing, which was, as you can see in the further slides, considerably lower than the previous one. So this was the questionnaire which we made. It was very simple, and we just had to monitor any the visual analogs before and after sequencing. So what we found was pretty interesting, that there was a very significant difference between the visual analog scores before and after sequencing, and we used some statistical tests on that, and the best thing was that all the 10 participants were able to express some kind of emotion after the stimulus. So this was the best thing, that we had 100% response rate. And as you can see it in the figures, that the most frequently recorded was around 6. This was before sequencing. I mean, this was something that majority of them experienced, around 6 out of 9 on the scale of 9. And when they were sequencing, the later one dropped down significantly. As you can see that it was, the highest one was around 3 or 3.5. So it tremendously decreased to half when they sequenced. So in this graph, it's pretty clear that the VAS or the visual analog before was almost double than what it was afterwards. And we can easily see a general trend of a decreased vision analog score post sequencing. So this resulted in a statistically significant difference between the two data sets, and this showed a very significant outcome from our study. So in conclusion, what I would like to say is that there needs to be some form of sequencing or calculation to overcome fear, anger, happiness, and sadness. And for that matter, any emotional stimuli might blunt the emotion, and it will not produce extreme emotions. Because if we do not have some kind of sequencing, we might result in disastrous consequences. So this is extremely interesting, and it opens a different new aspect of research, and especially not only for neurosurgeons, but for even those who are in cutting edge professions like F1 drivers or jumpsuits or and all those kind of cutting edge sports where they need to overcome their fears before getting into that profession even. So this is even for doctors who are going through a tough time in their studies or everything. Anything which makes you stand back, you need to just sequence, and you need to have a blunt effect of the emotion which is stopping you from doing that. So conditioning or repeated exposures to similar scenarios can help in a great extent, and that is why this is a method of training our warriors and surgeons even to tackle the situations when it comes a hard way. I think Dr. I will be better able to explain this, because this is something which requires experience. So of course, emotions is something which makes us what we are. If we do not have emotions, we are beasts simply. But the need to control these emotions makes us a better person. So this is the end. It was a short thing, but I would like you all to make note of this first workshop which we are conducting under the Young Neurosurgeon Society. It will be hosted in Nepal, November 29th to 30th, and I welcome you all to be a part of this. We will be announcing the registration soon, but you just please save the date. This is mostly for the medical students and young residents. So all the panelists who are here, I would like you to share this date with them, and we welcome all medical students for this. Thank you all, and that's it from my side. I stop my screen share, and
Okay, Hera, thank you very much. A busy girl arranging this program, putting together a presentation. And Ipe, since you were one of the co-authors of this paper, do you have any comments to start things off? You gotta unmute, Ipe, unmute.
Yeah, excellent way that Hira has put this across. I mean, I would be continuing the talk later on as to telling what's the significance of this study. I would give some examples from every single walk of life, and more than that, how important it is for neurosurgeons, soldiers, some of the cutting-edge sports personalities that I know. When panic grips them, how do they cope up? So it's although this study has a lot of p-values and graphs, it may look a bit, for a person like me, it may look a bit, not so interesting. But it's an extremely important piece of information for everybody in cutting-edge positions. Of course, not for probably for people who are sitting from morning to evening in the same shift, or those people who are doing gamma knife surgery, with all due respect to them. But people who are doing people who are aneurysm surgeons, or maybe skull-based guys, or race car drivers, this is the piece of information that you need to have. I'll continue on after Hira, and I'll tell you why.
Okay, let's just get any more comments from the panel, comments or questions of Hira. Go ahead, Rosanna. You need to unmute first, please. Unmute your microphone. There you go.
No, I think it's very interesting study and very interesting topic because as Sherian said just now, I think will be, I'm sure that those people who can, participate in the Formula One have a different brain than regular people and different connection, because they don't have the same, I think, the same fear that, regular people, definitely. So their cutoff, maybe it's completely different. I think it's the same for surgery. I think it's the same for neurosurgery, because sometimes I meet a neurosurgeon who is scared to do some difficult operation. I mean, this means that maybe probably neurosurgery is not for those people. I think if you choose neurosurgery, you need also to face difficult operation, especially, yes, vascular and skull base, which sometimes require really special skills, training, but also attitude to fear. So some people probably don't have this attitude, and they may not realize. So we should understand if we have, for example, maybe an MRI with even, I guess nowadays we have the diffusion sequences, we have, special advanced MRI. So we did very much progress in this field. I'm sure that in a few years we are able, with just a simple MRI, to understand if we can fit for a kind of job, because some people, I guess, they don't realize, until they face the problem, until they face the complexity of the job they choose. And this is, I think that will be interesting to understand. I'm sure that we will reach that.
Okay, any other comments from other panelists? Peter, Margarita, Juma? Before we go on with Ipe. Okay, Margarita, do you have anything to say? Go ahead, unmute Margarita, please. Margarita, please unmute.
Mute, okay.
There you go, okay.
Mira, thank you very much. It's a very amazing presentation for you. And I would suggest to you to read Gardner works He is from Harvard School of Neurology. He has a lot of articles about fear, anger, and also joy. And he advised us that a difference between generations. He put a cutoff on the Second War. Before the Second War, he advised that this generation is more related to fear and fight program. And the new boomers from Second War from now are more related to joy and happiness. It's a very good book. It's called The True, the Beauty, and the Good. I advise to you to read it because a very interesting point of view. Okay, thank you.
Okay,
Okay,
very
thank
good.
you. Thank you so much. Thank you. I'll do that. I'll read that. Thank you.
Very good. Any other comments or questions before we move on to Ibe's talk? Okay, very good. I guess we'll hang on to Ibe's talk on forebrain sequencing. Why don't you take over, Ibe? Okay, Ibe, you're muted. You're muted, Ibe.
What is that author's name, Margarita? What is that author's name? Gardner Welsh?
Yeah, Howard Gardner. Gardner.
Gardner?
Yeah. He studied about multiple intelligence and about feelings. It's very interesting author. And in Brazil, the book received the name The Good, the Truth, and the Beauty. It's a very interesting book.
Okay, very good.
Margarita, could you please write down the name on the chat panel, please? If you
Yeah,
can.
yeah. A minute, please. I'm still.
Well, you know, once we learn how to use these tools here, we'll just be writing that on the screen.
Okay, let me see you, Hira. I'm writing on the chat, okay?
Yeah,
Howard
all right.
Gardner. The truth, the beauty. Did you receive it?
Yes, thank you. Thank you.
Welcome.
Thank you.
Very good. Ibe, do you want to start your presentation? You're next, correct? Could you start your presentation, please?
Yeah, I'm going to continue on what Hira talked on. And I'm not going to present, I'm going to talk to you. It's going to be an interactive thing.
Okay.
Now, before we started the study, you must know a few things. You know, the old wisdom, if you look at it, if you're angry, people told you to count to 10. People never figure out why it is, but it's the truth. If you count to 10, people think it is to wait, but it's not to wait. It is your forebrain. Your forebrain is doing a sequencing, which means you're counting from 1 to 10. You're using a forebrain activity. And that depresses or that suppresses your pappus circuit. Now, if you had premature ejaculation, people would tell you to count backwards from 10 to 1. That's even more complex sequencing. So that would probably get the rush of your parasympathetic pathway to lessen. When you went to war, you always shouted something. Before your final rushing, you shouted something. If you see every war, nobody goes in silently. If you are facing another army, I mean, of course, the commandos go in silently, but even they do something. Now, if you were in grief, Many religions ask you to pray. And when you go for all this rehab, they pray. And what is prayer? Of course, religious things do matter, but other than it, prayer is sequencing. In Hindu philosophy, when you have fear, you are told to repeat mantras, especially something called the Hanuman Chalice, which means that you will be reciting something and the fear goes off. For small children, you are asked to say something. This Hanuman Chalice is a mantra, is a prayer. So you keep on saying it and then your fear vanishes. And in neurosurgery, one of the things that I do, for example, when we have really worrisome things, when an aneurysm ruptures, you focus on the rupture, then, you're going to really panic. After doing about 500 aneurysms these days, I know that I am away from this field of rupture. My mind is thinking about the scan. I'm sequencing actually. I'm thinking, where is the A2? Where is the other A2? I'm not thinking about the rupture. My mind is sequencing. My mind is not thinking about the rupture at all. I'm looking at how I can clip this aneurysm. It is an opportunity for me because the aneurysm is ruptured. I don't have to put in a temporary clip anymore, or I don't have to worry about anything anymore. If I clip it, it's done. It's an opportunity. So I'm thinking about how to do it in the most beautiful manner. So I'm thinking. So this is the secret. So I know about some of the best shuttle badminton players. We have some of the top of the world shuttle badminton players. And one of the things that they used to face before was when they faced the Chinese players, they were consumed by fear, completely by fear, because the Chinese players were so good. And although after the game, they thought that they could really have won, but if not for the fear. So what they did is they went to the Chinese league, they went to China to play, and they got familiarized. And they understood that there was not much of a difference between these players and you. The only thing was, there was this myth about these players that made them, say for example, Lin Dan was a legend, and playing against him itself was a factor for fear. So these guys went to these places, to China, and they played. They invited these guys back to India. They played with them, and the fear factor went away. So what is that? Familiarizing, after familiarizing, instead of fear, you start to think about how to counter his serve, how to counter his movements. Instead of fear consuming you and making some wrong decisions, you start strategizing. So this is forebrain activity, which actually suppresses your fear. Now, if you look at the origin of fear, fear is extremely important. If you don't have fear, you don't survive. Especially when we were in the jungle. If the child jumped from the mother's safe hands down from the tree to a waiting lion, you would never, there's no way you would mature to be an adult. So fear was extremely important actually. And if you have a resident who doesn't have fear, he will be called a disaster. Suppose, imagine a neurosurgical resident with no fear. He would do everything, and his second name would be disaster. So fear is extremely important, but you must understand, in the jungle, if you look at it, since my interest also is trauma, in diffuse axonal injury, one of the earliest things to go is your is your tract which connects your temporal lobe to your hypothalamus. The stria terminalis is a tract which connects your temporal lobe to your hypothalamus. That is your fear connecting to the hypothalamus, which creates it to panic. And probably when you grew up in the jungle, maybe all the bumps and bruises and all the fights you picked up may be responsible for the stria terminalis to get damaged later on as to adulthood. And then maybe this was why you were not so fearful, or you were not paralyzed with fear in your later life. If you look at boxers, you know, one of the things that you see if you have fought, after the third round, how much ever hits you take, you're going straight for the other guy. You don't have any fear. You're going straight for the other guy because probably your stria terminalis is taken a hit, and at least a transient hit, so that your fear is gone anyways. And then the only thing you're going for is the other guy. I mean, if you see fighters, the first few rounds, they're going to be very circumspect, and after that, they're just going for it. So stria terminalis is one of the things that which causes this panic, your paralyzing fear. So fear is good, but not paralysis. So if you are doing a procedure, for example, if you're clipping an aneurysm, while you're clipping it, you have fear. Of course, when you're exposing it, you have a fear whether it is going to rupture on you. But sometimes I have experienced this, that when it ruptures in my earlier aneurysms, I focus on the rupture, and then, I mean, you just want to close and come back. And it's only your character which, it's your metal which finally shines through and makes you do that, although you're really, really afraid. But there is a way to overcome it. And the way to overcome it is the sequencing. So that's what Hira was saying. So looking at all these examples, we understood that from very primitive era, people knew what fear was and people knew how to overcome it, although we didn't understand the mechanism. So we wanted to do this study. We wanted people to do sequencing, just not prayer or not something else, but sequencing, pure sequencing. And I think the more complex it is, the lesser the fear, the lesser the emotion. Can you laugh uncontrollably when you are doing math? It's impossible. You try doing math and hearing a joke. You cannot laugh. You can laugh maybe, but you cannot laugh the way you laugh uncontrollably. It's impossible. That's why comedians, they need complete attendance. If anybody in the audience is doing something with the phone, they go crazy because they cannot make people laugh if they are on the WhatsApp or they are on Instagram, and they cannot make people laugh. So stand-up comedians have always this rule that you cannot put your phone on, or you cannot be on the phone if I am trying to make you laugh. The same for neurosurgery. So F1 drivers, or guys who, when you do bungee jumping, I have done a variant of this bungee jumping. We have done paragliding, and before you step off, it's extreme fear. And the only way you can do this, we tried this, we can do this, is try to find cube roots. 1, 2 cube root is 8, 3 is 27, 4 is 64. So you find doing that, you try doing that, and your fear just disappears. Not only fear, any extreme emotions will disappear, because stria terminalis, I think, will be overridden by forebrain sequencing, probably by the callosum. We need to figure out what is overriding the stria terminalis in these kind of lesions. You know, there are people who have no fear. That is, when people have bilateral lesions of stria terminalis, they have no fear at all. There are many cases, you can read up this. But can you functionally override the stria terminalis? Maybe yes. Maybe by sequencing forebrain activity. So this is just a start. This is an idea which will really change lives, which will change a lot of concepts about real cutting edge things. And the next time you encounter this paralyzing fear, maybe you should start counting, not 1, 2, 3, 4, but maybe 1, at least square roots, 4, 9, 16, and so on. And then this fear is going to vanish. I can be sure of that. Maybe anybody who has GAD, instead of giving them these medicines, I know a lot of surgeons taking propranolol, alprazolam, or alcohol even before surgery. Instead of that, maybe they should, during the surgery, they should probably talk to somebody. Talking which involves a little bit of focus. And that's going to take off the fear. This is very good for young neurosurgeons. The older neurosurgeons have figured out ways to do sequencing without all this. So anybody who says that I've had no fear, I'm very brave, is lying, or they haven't done real cutting edge neurosurgery. How much ever bold you are, you experience fear when you start doing real cutting edge neurosurgery. And sometimes what has happened to you in the past scars you. And sometimes if you had an aneurysm rupture and your patient died on the table and then you had to go through a lot of crap, it really affects you for the next case. Sequencing helps there as well. If you can divert these thoughts, you can do your next aneurysm, have a positive feedback, probably. You know, Yuha is with me, and Yuha tells me that he's had several disasters, and I've had myself, in the last 10 years, I've had several disasters. So if I remember just that, and I go for an aneurysm or a skull base, it's impossible to even open. I would rather give up before even starting the case. But one of the things that I have trained myself is to think about the technical aspects of the case rather than to what happened to me in the previous case. So if I look at the scan and I make a strategy and I keep on progressing on that strategy, I'm able to take out these things. Or I'm able to drill the posterior clinoid process. Or I'm able to clip a very, very difficult aneurysm. Because I divide these aneurysms into steps and I keep on following these steps and I say, okay, step 1 completed, step 2 completed, step 3 completed, and this is how I do it. And I know many neurosurgeons who do the same thing. But if you focus on the whole thing and how difficult it can be and what is going to be waiting for you next, it is like one of the tightrope walkers whom I talked to once. I asked him, how do you walk without any safety? I mean, if you fall, you're dead. So he said to me, I focus on the next step, the next piece of rope that I'm walking. I don't focus, I don't think about where am I going to fall or what happens to me if I fall. I don't focus on that. I focus on only the next piece of rope that I have to put my leg on, and where is it, and where is it, and how am I going to put my next leg? That's all. Nothing after that. So this is extremely important, and this is a scientific way of overcoming these extreme emotions. And I hope this may, not only in cutting edge sports and neurosurgery, this may help a lot of people with extreme fear as well. Thank you very much.
Very good. Very good. I thank you very much. You know, I guess every specialty has a catastrophes. I know in the emergency room, a pressure pack situation was when a patient came in that you had to intubate. Are aneurysms the most nerve-wracking operations? Are they the most stressful in your experience?
Skull base is equally nerve-wracking, but aneurysms for a short time, when you, for example, for an aneurysm like a basilar, when you don't have proximal control, or like a distal ACA where you don't have any proximal control, you have millimeters to go in. And if that ruptures, you know that this patient is not going to do very well. Mm-hmm. So if you look at what's going to happen and your access, and sometimes it happens, and maybe it has happened to you 3 or 4 times in the past, and this further complicates things. And yes, aneurysms can be nerve-wracking, but skull base also. For example, if I am drilling a PCP, when I'm drilling the posterior clinoid process, I have a 3 millimeter window and I have a 1 millimeter drill. I can move with my drill only 1 millimeter to each side. If I move right, it is the optic. If I move left, is the carotid. If I move front, is the A1. So, and if I plunge, it is a C5 carotid. If I go down a little bit more than I should, it is C5 carotid. So when the drill is moving, I can hardly see and focus. But PCP drilling is so essential sometimes to get proximal control for some aneurysms and for sometimes for cystinostomy. But this has to be done. People don't do it. Many people, I can count maybe less than 10 people who would do it in the whole world. This is because it is extremely, it can induce fear. If you ask this to be done in a model, I'm sure maybe 70% of neurosurgeons can do it because there's no fear. But if you ask it to do it on a case where all these arteries are around, it's not so easy. So it is the fear which is, causing them to create mistakes. So, well, that's the answer.
Okay, during residency, there's no formal training on dealing with stress. You just kind of learn it as you go along from mentors and other neurosurgeons.
Well, one of the things I've seen is if you think too much about yourself, that's one thing which induces a lot of fear. Because I've seen a lot of guys who think too much about themselves. And when you see them operate, they have to live up to a lot of expectations. And then they falter. They falter miserably. So one of the things is, as a neurosurgical resident, you need to learn how to speak the truth, how to be completely honest, and be critical of yourself, and to admit that I've made mistakes. So I've seen a lot of guys who think the world about themselves. Like, in their talks and all, I mean, I get a letter saying Office of the President and all that. So, I mean, and when you see them, actually, it's a bit sad how they operate. So maybe one of the things that you can avoid as a neurosurgical resident is to understand that you can make mistakes and you have to start taking baby steps, and you may not be as good as everybody projects themselves to be, because people only project the best surgeries of theirs. So I I always try to put in my videos my bleeding. I mean, when my resident says that, oh, this is not good, I say, yeah, this is what you have to put. Because otherwise, every resident thinks that every surgery is bloodless and amazing, and they try to emulate it, and when they cannot do it, they have fear. I have gone around in almost all the so-called best surgeons ORs. I have seen how surgeries are, and including my OR, I know. I mean, if I show something very rosy, it's not how it is all the time. It can be bad. The post-op picture can be very good, but the surgery may not look very good. So anybody who sees all these rosy images and shows these rosy pictures, I mean, they are bound to have fear. That is when somebody is not honest with themselves. If somebody is honest with themselves, taking out a meningioma, you show only the first and a few parts where there's no blood. And taking out a petroclival meningioma, you show a 2-minute video clip, and you show a post-op scan. That's not what the surgery is about. A petroclival meningioma is definitely more difficult. Even during craniotomy, you can have a lot of blood loss. For example, if you show a DAVF surgery without blood, you know this guy doesn't, I mean, he's a very big optimist. I mean, he's not showing the blood at all. Okay. So during the craniotomy, you can lose a liter of blood in the DAVF. Not that I lose it right now, but I mean, I have lost a lot of blood. I mean, enough blood to let my anesthetist tell me, you must probably stop this surgery. In a DAVF, I mean, you do a craniotomy and you lose that much blood before even your craniotomy. So if you are honest with yourself, then you really don't need to fear. And you understand that you are slowly growing up. Even now, if I have a situation, I always tell my boys that I will try my best. Let me see what we can get. Maybe to the next step, perhaps. Maybe to the next step again. I will not tell people that, oh, I am the best. I mean, the residents, I feel that they see these guys and they get some wrong impressions that, you know, neurosurgeon is like, you know, like James Bond. You can, or you can split a card with a bullet and all this. This is not possible. Of course, skills are very, very important. I believe religiously in developing skills. But these guys who are James Bonds are not really James Bonds. So you should see them in theater. They are probably much lesser than James Bonds. They are not even, well, I wouldn't want to say anything, but they're not anywhere there. So, and so you should not see all these rosy videos and then get an image that everything is fantastic and everything is fabulous in neurosurgery. No, you should know the real truth. And then fear may not be a problem. The next time you have a bleeding, you think, oh my God, I mean, I had bleeding and that guy is so squeaky clean. It's not so. I mean, that guy, when he started, it was not squeaky clean. So if you remember that and if you understand, I mean, this is one thing which can take off. And then this sequencing really helps too.
Okay, very good. Margarita or Rosanna, do you have any feedback on stress in the operating room for the neurosurgeon? You're muted, Rosanna and Margarita. Okay.
Yes, Professor. I'm very grateful that Professor Lippi speaks so frankly about fear and neurosurgery, because sometimes I just started my career, I felt so insecure with huge tumors. And well, thank you very much, Professor Lippi, because when I go to the Congress and I see those amazing presentations and I feel that I have to learn so much. Thank you very much, because when a big neurosurgeon like you, sir, come to us, the youngest, and show all the truth, it's very important. Thank you very much. I'm very proud to be here. Thank you.
Thank you. Rosanna, do you have any comments?
No, I'm very grateful as well to Cherian for the comments. I think that they're very important, and I agree, totally agree that you need, yeah, you learn by mistake basically that we do, unfortunately. Yeah, and yeah, you are scared when you do the next time the same operation because you had, you know, before you made a mistake, because it's not just the patient. So many people say, oh, the anatomy was difficult. It's not the anatomy, it's just ourselves, our profession. So, and we should just avoid. That's the because everybody made mistake. I mean, unless that you don't do surgery. I think those people that who have no mistake, they don't do surgery. That's the explanation, unfortunately. So, and so we should improve, we should learn, we should also, I think, go around the world to see those who are more experienced neurosurgeons, because there are people who are very experienced who deal with difficult cases every day. And I think to learn by these people can definitely improve our also self-confidence, our knowledge. So if you are all in your department close to see only few people all your life, I think you will never be able to deal with complicated cases. Unfortunately, they come to us, these complicated cases, and sometimes we are not able to do because we didn't learn by those who are dealing with these cases, with this surgery. So it's important to go around the world and see busy neurosurgical department who are doing this kind of surgery. That's the way. And also microsurgical technique by anatomy, by cadaveric dissection. That's also important. It's different. As you said, it's completely different when you do anterior cranioidectomy in a cadaver and you do in living. So I think it's completely different technique and fear. So thank you very much for your comments, really, very important.
Thank you, Rosanna. Juma, do you have any comments on the stress in the OR for the neurosurgeon?
I would like to thank Professor Aip for his contribution. I usually remember his words, you should have your fearless focus. So we are really honored to learn from him how we go about these complicated cases. How does he remove the fears? How is correlating anatomy and anatomical, radiological parts of the management. So really thank you, Professor Aip. We are really honored to have you here and we really learn from you. Also, thank you, Dr. Hira, for the presentation.
Okay, thanks, Juma. And the students, Hira, Peter, any questions, comments for Aip?
I would like to make a comment that while we were doing the study, this was something very new for me, and this has opened up a lot of scope and focus, and you know, it has changed how we perceive things in life. And I believe that there should be a setup even during residency and for young neurosurgeons to have an interaction with senior neurosurgeons, and they can tell them of their experiences just like Professor Ike did. And we can get motivated at times when we are not able to do something which is required of us. So there needs to be some counseling or some kind of a session even during residency, just like you also pointed this out, Dr. John, that this does not always need to come with experience, but also because through counseling, and they need to be prepared that what are they going to face ahead. So maybe this is the entire motive of having this neurosurgical community and having an interaction of going to be neurosurgeons with senior consultants. So this will bridge the gap and bridge the experience gap, I believe.
Very good. Thank you, Hira. Peter, any comments, questions? Unmute, Peter. Peter Oslaven.
Oh. Yeah. So thank you so much for the presentation. And So far I'm just a medical student, so maybe I don't have any experience about stressing in the operation room.
Okay.
Yeah.
Okay. Well, you'll see it. You'll see it.
Yeah.
Slaven, any comments, questions?
Yeah, I will just say briefly that I'm thankful to Dr. Cherian for always mentioning these psychological and other aspects of neurosurgical practice. So I think that really if some of us manages to become a neurosurgeon one day, we will carry a lot of these lectures of how can I say, way of thinking and coping with stress from him. And I must say that especially in this lecture, I really wished that I can become and cope with this stress as soon as possible. It really motivates me more just to be able to become a better version of myself. That's another motivation I found while listening to Dr. Cherry. So I'm really thankful for everything that you provided. I'm not sure if it's the experience with the Neurosurgical Super Sunday, but I really enjoy each and every of your lectures in this regard. Thank you very much.
Okay, very good, Slaven. Okay. Okay, I guess that kind of wraps it up. Mike, any closing comments? Okay, very good. Okay, we'll go on to the next presentation. I believe Hira is Dr. Afnan here yet?
Yeah, she's here, John, as an attendee. Can you promote her as a panelist?
Okay, go ahead. Why don't you introduce her? Go ahead.
No,
take
she's
over.
she's
I'm
here
sorry.
as an attendee. She's not on the panel. So you need to put her on the panel.
Oh, okay. Oh, I'm sorry. I'm sorry. Attendee. We're learning this platform. Afnan. Okay. More. Promote to panel. Okay, there we go.
Yeah, there she is.
Yep. That was a semi-stressful event. Okay, let's see. I believe she should get on here. Able to come on?
Yeah, she is here. She is.
Okay, there we go. We just need to unmute. Dr. Eftan, could you unmute your microphone? It's at the bottom left of the screen. Oh, there you go. Okay, very good. The bottom left of your computer screen is a mute button. You need to unmute yourself.
Hi.
There you go. There you go. Okay.
I need to share this screen.
Yeah. Okay. Before we start, we're just going to go around and have everyone quickly introduce themselves. I'm Dr. John Bennett from Miami Beach. This is our channel of Neurosurgery TV. Before you introduce yourself, let's go around so you can meet the whole panel. Okay. We'll start with you, Rosanna. Could you please introduce yourself to Dr. Afnan?
Yes. Hi, I'm Rosanna. I'm a neurosurgeon. I work now in London and I train in Helsinki in Shanghai.
Very good.
Welcome.
Welcome. Okay, Margarita, could you please, are you there, Margarita? Don't know if Margarita, she may have stepped away. Okay, Ipe, could you please introduce yourself to Dr. Afnan? Unmute, Ipe.
I'm Dr. Sherian and I work in Nepal. I am a neurosurgeon.
Very good.
Welcome.
Very good. Ipe, Juma, could you please introduce yourself?
My name is Dr. Juma. I'm doing my fellowship in India, spine and neurosurgery.
Very good, Juma. Margarita, you're back. Could you please introduce yourself to Dr. Afnan?
Hi, good morning. My name is Margarida. I'm a neurosurgeon. Now I formed in Brazil. Now I live in Porto, Portugal.
Okay, very good. And Slaven?
Hi, welcome.
Slaven?
Hello, my name is Slaven. I'm a medical student from Zagreb and one of the administrators of Neurosurgery TV. Thank you.
Very good, Slaven. Peter?
Hello, I'm the medical student currently studying in Italy.
Welcome, Peter. And Nofil, doesn't have his camera on, but can you hear us, Nofil? Could you introduce yourself? He's muted. Oh, that's okay. Okay, Dr. Afnan, welcome. And could you please introduce yourself
Thank you.
before you go into your presentation?
everybody for the invitation. Actually, it's my pleasure to be around you and to share this experience with you. So this is Annie. I'm a senior neurosurgery resident at Saudi Arabia, King Faisal Specialist Hospital from Jeddah. Is my voice clear?
Yeah, your voice is clear. Your camera doesn't seem to be. There you go.
All
There
right.
we go. Okay, there we go.
Is it fine now?
Yes, it's fine.
Okay. Thank you. Around you and share this little talk with you. So I have listened to the
Okay, please be patient. I don't know if the panelists can hear me, but we have some connection problems in Saudi. Can anybody hear me?
Yeah, I can hear you, John.
hello.
Yeah, I believe Dr. Afton has some connection problems.
Yeah.
We'll just persist
back
and hopefully. Okay, good. Go ahead.
So I have the sharing button. It's here around.
Well, we'll do the best we can. It's a little difficult, but just
All
continue,
right.
continue on.
Okay. So actually, I neurosurgery. I prepared a little talk. I hope you find it useful. Sorry. I think I came late, so I'll just sum it.
Okay, we're not seeing the screen yet, Dr. Afnan.
Are you sharing the screen, Dr. Afnan?
Yes.
Oh, we cannot see your screen.
Oh, now?
Did you share your screen?
Yeah, I have shared it.
Oh, we cannot see your screen.
Okay. Yeah,
Okay.
I can't even see your picture.
Can you unshare your screen and then do it again?
It again. About now? Seems like it's shared now.
No.
Oh, really?
No, it's not sharing.
She's to share and to share again.
Sure,
Yeah.
please.
Okay. Is it working now?
We can see you, but not your screen. So can you share it again?
Okay. Stop. Okay.
You know, I don't know how to blue box. For some reason here, your screen is showing, not hers.
My screen?
Yeah. I just see you on the screen. I don't see her. I don't see Dr. Aftan for some reason.
We should all mute, I think, so the person who's speaking should be on the big screen, you know,
Yeah.
because the speaker is being popped up. Okay.
Yeah. Okay. No, Dr. Aftan's not on mute now. She should come. I think maybe a connection problem. It's a Wi-Fi connection. Can you hear us, Dr. Aftan? Nope, she just dropped off there a second. Yeah, this is a different platform. No, and normally in the Google Hangout, you can lower the requirements of the bandwidth. I'm not familiar with this platform, if you can do that too. If someone has a Wi-Fi, decrease the need. Are you familiar with that on this? Oh, there we go. Okay, Dr. Aftan.
Yeah, actually, I'm back. I'm trying another.
Actually, we could share the PowerPoint if you want to send it to us. Is it a big file?
कमरे में पड़े हैं मैं देता हूँ मैं वो लेक्चर ऑनलाइन सुन लेता हूँ
Okay. Is it a big, can you send the file to us, Dr. Afnan? We can screen share. You don't have to.
Yeah, I've asked her to email me just a second.
Oh, okay. That might be better here unless she has a big file. Because the connection is not too good, so it might be tough for her to screen share and talk too. Is anybody familiar with this platform, how you decrease the amount of bandwidth that's required? Hey, let me go into the panel now. I'll try to investigate. So just hang in there and be patient. Recording management.
काम ही किया ना हाँ
Okay, I'm going. Did you ever hang out before with Dr. Afnan and Kira?
Yeah, I had it last night and it was pretty.
No problem.
No, there was no problem because today she's at the hospital and she's saying that she's having troubles there.
Oh, she's like from a different connection that she used when she
yeah.
A Wi-Fi connection. Well, we'll keep our fingers crossed and try. Sometimes it works out, sometimes it doesn't. And I went into the database for Zoom to ask how do you decrease the bandwidth of a setting, but there's no answer for that. Well, I'm saying that people come on the panel, you can promote them to be, if they come and attend, you can promote them to the panel.
Okay, she cannot be reached on WhatsApp either because I think she has a very bad connection there. So I'm not able to talk to her on WhatsApp even.
Okay, oh, you don't have her PowerPoint?
No,
okay.
Just a second.
That might be a solution, and she could just talk. She could actually just do the audio and not even a video. Do you know what I'm saying? She could turn off the camera and just do the audio, accompanying the PowerPoint. Be patient, everybody. Maybe it'll work out.
John, she has a very unstable connection, so she's asking if there's a possibility we can delay it to next week, maybe.
I think that's probably the best course of action. Yura, what do you think?
Yeah, I think we can postpone this to next week because she has a very unstable connection and it won't
Yes,
be
yes, yes, yes. Hopefully, I was hoping it was clear up, but it looks like it won't. So, panelists, thanks everybody for coming, and we'll get better with this platform, and we'll keep in touch. We have a webcast on Tuesday with the Sudan Neurosurgery Society, and you're all welcome to come to that. I'll send everyone a link to come in, and we'll get better with this platform. Thanks, Hera, for all the work you did getting this together and putting the graphic.
You're welcome. I would like to just put a share on the, I just like to share my slide for the ACNS conference, which is coming up in November, so that the panelists can have a look at it for once before we go, all right?
Yeah, sure.
Yeah. So this is it. Can you all see this?
Yes.
So this is our first workshop by the Asian Young Neurosurgeon Society. I welcome all the panelists and I would like you all to spread the word regarding the dates. And we will be updating on our Facebook page and our website too. And soon we will be opening the memberships for the society. So please stay updated with our upcoming events. Thank you.
Very good. And so people can register on your Facebook page.
Yeah, they can message us on our Facebook page because our website portal is still under construction. So they can message us on our Facebook page.
Very good.
All right.
Very good. Thanks everyone for coming. I'll stop recording.
Thank you very much.
And then, okay, very good.